Dr. Gudiño, thank you so much for being here. It is an honor to introduce you today. So my apologies, my lateness is not at all a reflection of my lack of excitement. I'm very excited.
Not a problem.
And all due respect for, I apologize for being.
No worries.
Let me talk about who you are and all your accomplishments. I'm really excited. You're an associate professor and associate director in the clinical child psychology program at the University of Kansas. Dr. Gudiño's program of research examines racial ethnic disparities in children's mental health and the delivery of evidence-based services to diverse youth and families. He's an associate editor for the Journal of Latinx Psychology, president-elect of the American Board of Clinical Child and Adolescent Psychology, and a member at large for diversity for the Society of Clinical Child and Adolescent Psychology. Please join me in a warm welcome. Thank you very much for being here. We're excited to get started.
Thank you so much for having me. I will say that I am sorry that I don't get to get a visit to San Francisco out of this. It's probably my favorite city in the US. And I will never get comfortable talking to my computer, but here we are. So I'm happy to be joining you virtually. And today the topic is thinking about the mental health service use of Latinx youth. And I hope that this can be a conversation that we have as we move through the presentation. And for the time that we have today, I'm really focusing on the identification of need and understanding patterns of care. So there's obviously a much more complex picture behind this, but the focus today is really on identification of need and thinking about the patterns of service use that are relevant for Latinx youth. I will say I don't have any conflicts of interest to disclose. Some of the work that I will be talking about today was conducted in partnership with the Office of Behavioral Health when I lived in Colorado. So I wanted to acknowledge my partners and funding sources there. I also wanted to briefly mention that we're not making the slides available only because there's some data that's not peer reviewed and ready for broad scale dissemination yet, but I'm happy to create a version that doesn't include those data or to send you any resources that I mention if you just email me directly. But I want us to start thinking about a case. So if we think about Miguel and we think about a 12-year-old Latino male in the 7th grade who as a young child experienced emotional abuse at the hands of his father, witnessed domestic violence, witnessed his father abusing drugs and alcohol. His father left home when Miguel was 7, and since then, Miguel and his mom have experienced housing instability. He lives in a neighborhood with high rates of community violence. He's witnessed shootings at a park near school recently, and he has internalizing symptoms, anxiety and depression, but it's his externalizing symptoms that are what's being noticed by adults. And at this point, school is threatening disciplinary action. And the questions we might ask ourselves is, how is it that Miguel is going to get services? If and when would he get services? And what's going to get in the way, or what's going to help, right? And that's kind of the context for our focus today. How is it that Miguel might receive services? What's going to get in the way? What's going to potentially help? So when we think about service use, we know that racial disparities exist. So this isn't new. And I think of that as the what. There are disparities out there. However, what we need to really focus on is the how and the why. That often we don't spend enough time really thinking about how and why these disparities come to be. And the reason for focusing on or shifting that focus more towards the how and the why is to really understand those mechanisms, understand ways to intervene. Again, given the time frame that we have today, the focus is going to be a little bit more narrow, so we're not going to get to talk about the entire picture, but that we'll start to think about how and why identification of need is relevant and what we might do about it. So the objectives for today are that by the end of this conversation, we'll be able to describe patterns of mental health service use for Latinx youth, that we'll be able to identify barriers to care at different levels, that we'll be able to discuss differences in how caregivers and providers perceive youth needs, that will list factors that are related to unmet mental health need for internalizing problems specifically, and that we'll start to think about ways to modify our assessment and engagement strategies as a way to address unmet internalizing need, in particular for Latinx youth. So as we start thinking about barriers to care, right? As I said, this isn't news to anybody that there are barriers to care, but it's important for giving it just a little bit of context. So as we step back and say, what's the evidence that there are barriers? You're coming from a child psychiatry area where this isn't news to you, that there's high rates of mental health need, and yet about 80% of kids with mental health disorders or mental health needs do not receive mental health services. So we know that there's a broad overall need. However, we also know that there's disparities in access to those services, where we find that Latinx youth, Black youth, and Asian youth, when compared to white youth, are less likely to receive mental health services, experience greater delays when they do receive those services, and that overall they report greater access problems. Now, we know that these differences can't be attributed to just differences in the prevalence of the disorders or the level of severity or the level of impairment. So these appear to be bona fide differences in the likelihood that a child receives mental health services when they have a need, and that differs by race and ethnicity. And again, we've known this for a long time, although we really drew attention to this back in 2001 with a report from the Surgeon General, really focusing around mental health, culture, race, and ethnicity. So back in 2001, it really got that federal attention. But when we look at trends following that report, we see that those trends remain. So that even though we started to pay more attention to the fact that there are disparities, that we still see those playing out even after that report and continuing on to today. So these are just some data looking at medical expenditures. And this is the largest, most comprehensive national data that we have. So it's focused on 30,000 youth, ages 5 to 21. And it's one way of showing that these disparities continue to happen even after this federal attention to understanding and unpacking disparities. And what they found is that Black youth and Latinx youth in particular continue to have higher rates of unmet need over the next 5 years. And that even when we look at those that have mental health needs, so those that had a need in the first 2 years, we looked at what are the chances that they receive services in the subsequent study period. That even then, it's only 10% of the white youth that ever initiated services. So really low numbers of initiating services, and yet about half as many Black children and Latinx children initiated services over that time period. Now, the one hopeful piece there is that when they looked at expenditure data, the differences were really tied to the initiation of services. That's where things really differed, that once kids were receiving services, they didn't find differences in expenditures. So this is one way for us to really start to think about the importance of paying attention to that initial access to services. And just as a caveat for today, we're not going to talk about quality of care, which is obviously very important, but this is just to really think about the importance of just creating access to the services that we already have. So in thinking about this, the start or the initiation of services, we really turn to gatekeepers and think about what is different about understanding kids' mental health. And here we think about the important role that parents, teachers, pediatricians, so that it's often these adults that are going to determine when services are warranted, when it's a mental health problem versus something else. They're going to facilitate those referrals. And thankfully, children have access to multiple influential caregivers. So there's a little bit of a safety net there where there's the opportunity for more gatekeepers to have some input to potentially recognize a need or to facilitate that need. At the same time, those barriers and facilitators are going to happen at that gatekeeper level, or it's likely that they're going to have the largest impact at that gatekeeper level. So it requires that as we understand disparities or try to understand disparities, that we step back and think about how is it that these family, community, and system factors are coming together to funnel some children into services while preventing others from accessing those services. So there's a paper in 2015. This was a white paper that was commissioned by the W.T. Grant Foundation. It was published by Margarita Alegria and colleagues. And what's really important about this work is that it provided a model for understanding the sources that lead to disparities in mental health outcomes. And they provide a good summary of data thinking about how socioeconomic status and childhood adversity, family structure, and neighborhood level factors drive disparities in mental health outcomes. Now, unfortunately, that report focused very little on service use. So they're much more focused on mental health outcomes and disparities in those outcomes. But it provides, it was a novel way to think about just having a framework for really thinking about this area. So one of the things that we've started to do in our own work is to really think about what is the framework for understanding barriers within Latinx youth mental health. Here, I'm really just providing a context for thinking about barriers or what gets in the way. So I'm not going to provide lots of detail on this study, but I'm happy to talk about it more during our question period. But this is the work that we conducted with our partners at the Office of Behavioral Health in Colorado. And our goal here has really been to map out the range of barriers and the different types of barriers that are likely or potentially going to play a role. And these are initial results from qualitative focus groups where we met with families, Latinx families that had children that had already accessed community mental health services. We also met with Latinx families with children that had never accessed mental health services and with providers in those service systems. And really here, the question was, what are the range of things that make it challenging for Latinx children to access or receive services, right? So the goal here is really just to set that broader context or to set the stage for that broader context. And it's no surprise here that one of the themes that emerged is really thinking about barriers that happen at a societal level. And there was three major themes here. One was really thinking about the role that socioeconomic status plays, and in particular, low socioeconomic status. So a general lack of access to resources, not just for the family, but within the community, within the broader system. Themes also here about racism and discrimination and how this impacts the likelihood that families navigate and access and feel comfortable within different service systems. And the lack of representation of ethnic minorities in the field, right? Here, they really talked about things like when we think about the education pipeline, how many Latinx providers are graduating from college, going on to grad school, that we think about these broader factors and we often ignore these because they're happening at a broad level. Bless you. But that it's really important to be thinking about those as well.
Thank you.
A little bit more nuanced as we started to think about what's happening at the mental health system level, right? And here we really thought about or learned about how funding within our mental health services plays an important role. That every agency we talk to or providers that we talk to really recognize the importance of serving the Latinx community. But at the same time, they say we're already competing for funds, we don't have enough funds, and we don't really know what to do. They also notice things like working in really siloed systems where everybody's reinventing the wheel, or where there's an inability to really communicate with other parts of the system. So mental health not talking to juvenile justice, or juvenile justice not talking to schools. They also highlighted the limited agency capacity. So in addition to just funding, really thinking about how are we able to recruit and retain Latinx providers, those that are bilingual. So they talked about things like having to really focus on training and saying if we can get some really good practicum students here and maybe keep them for internship and hopefully keep them for long-term employment, that's really where they're trying to build that capacity. But at the same time, they notice that that's the challenge, that they're competing with the same students that other places with more resources are competing for. They talked about things like bureaucratic process and just the number of hoops that families have to jump through to get an intake scheduled or to be seen. And really finding it a challenge to understand why those processes are in place, how one changes them, how much of it is required by the state or the county. But again, thinking about why it's limited or a challenge for them to deliver what they want, which is culturally competent services, with the ability to provide those in Spanish. So really thinking about what's restricting the mental health agency from doing things differently or from recruiting those providers that can help support those goals. And then as we think about barriers happening at the family level here, we often talk about things like practical barriers. And these were very common again in our data as well. So thinking about the importance of childcare and transportation, language match, cost and finances. But here, what was interesting to us is to really think about what's different about mental health. So these aren't unique barriers, but when we're talking about providing a mental health service, we're often talking about a longer or a more open-ended course of treatment. So that even something like a copay, we say, well, they have insurance, but a $10 or a $20 copay really adds up if we're talking about an open-ended course of treatment or if we're talking about 20 sessions or more. So really thinking about the accumulation of some of these barriers, that they might not be insurmountable when we're talking about a single visit for an annual physical, for example, but that they become insurmountable when we think about them as they apply to outpatient mental health treatment, for example. And the other that is not going to be surprising to you is really thinking about how we align our schedules with family schedules. That if we think about most of our outpatient settings, some of us do work evenings, but even then it's not most evenings or all evenings, so that our hours are really set up in a way that creates a natural barrier with scheduling, or that creates small windows of opportunity for families to be seen. But the other category of barriers happening at the family level that we saw are really things around attitudes, beliefs, and perceptions. And here what families talked about is really just sometimes having a really high threshold for when services are needed. So it's not that they don't recognize them or don't think mental health is important, but saying in the broader context of lots of competing demands, there has to be a really high threshold for when this rises to the top. They also talked about sometimes challenges within the family, saying that there's disagreement about whether it is a mental health problem, whether accessing services is a good thing or not. So often it's alignment within the family that is also a challenge. They talked about being uncomfortable with providers sometimes, not being sure if they're going to be accepted, not being sure if they're welcome. They talked about stigma, concerns about how other people might see them and just what it meant to be receiving services. And there was also a unique theme around gaps within the family, so that the children, the parents, and maybe sometimes the grandparents really saw the problems as very different, or they understood they had very different ideas about what the correct course of action should be. And that often it started from lack of information, that they weren't sure what resources were available, when one accesses them, what services look like, so that it was often this big unknown, and there was disagreement about how one knows when to access those services. Now, one positive thing that we learned here is that, especially within the families that had never accessed services, they were incredibly open to the idea. So they were not reporting stigma as much, but they were really focused on understanding how does one access services that are preventative. They were saying things like, these groups are really helpful. Can we have more of them? So they really appreciated the opportunity to learn and to just talk about mental health. The big barrier for them was, where does one go to access preventive services, right? And that there's a big gap in our service system where we don't really have great coverage for general education and training and prevention around mental health, that we really wait for children that have medical need or medical necessity. So that was just a brief overview of some of the early work that we're doing to really think about how do we develop a framework for understanding these barriers, and how do we think about them at different levels, or what's impacting a mental health agency versus a provider versus a family member, so that we can then step back and really think about how is it that we can dismantle these disparities at each of those levels, right? And that there's likely going to require different interventions at each of those levels because they're different mechanisms or different processes. But within that broader context, for our purposes, we're really talking mostly to mental health providers. So we're talking about mental health, that we want to acknowledge that there are families that are accessing services and overcoming some of those barriers. And here we want to really think about what are those patterns of service access? Who is accessing services and who isn't? Right? We said there's a large proportion of kids that never access services, but those that do get to our door, who are those kids? Now, we started to look at these questions in some of my earlier work, looking at pathways into services. And these are data from the Patterns of Care study. So this was a large representative sample of youth in San Diego County, youth and families. And these were about 1,000 kids, ages 11 to 18, that were known to a service system. So it doesn't mean they were receiving services, but the family had some contact or open record with either child welfare, juvenile justice, alcohol drug treatment, specialty mental health, or special education. So this was a population of kids and families that were known to service systems. And here the goal was to follow this group of children and families that had a higher likelihood of needing or accessing services and to really understand what those patterns might look like. And for the purpose of the analyses that I'm highlighting today, we looked at a 2-year study looking at how kids access services based on the problem that they had. So here my questions are really focused around how does the type of problem that a youth has, whether it's internalizing or externalizing, influence racial disparities. And the reason for this thinking was that when we look at some of these systems, we see overrepresentations of Latinx and Black children. So when we look at juvenile justice, child welfare, for example. So the question was, why are kids overrepresented in some of these sectors? Are there some kinds of problems that they're much more likely to be identified for or to receive services for? And might this be the opposite when we think about internalizing problems, right? So when we think about those problems that are easily noticed by others, or that are especially notable for child welfare, juvenile justice, schools, are we potentially going to see some disparities here as a function of the kind of problem that youth have? And that was really the first question that prompted some of this work. And in that early work, what we found is that disparities were largely constrained to internalizing problems. So in this graph, what we see is that here on the left, we see the percentage of kids that received specialty mental health services in those 2 years over the course of the study. And we see the bars are for white children, African-American children, Latinx children, and Asian Pacific Islanders. So when we look at children that only had internalizing need, and here we're looking at clinically significant severity of symptoms plus impairment. So when they only had internalizing problems, we see the starkest differences in terms of disparities, where white children are at the highest levels, the highest proportion, about 72%, likely to receive services in those next 2 years, and a significantly lower proportion for Latinx and Asian Pacific Islander youth. When we focused on youth that only have externalizing problems, here again looking at severity and impairment, all of a sudden there's fewer differences across white, Black, and Latinx children, but Asian Pacific Islander youth continue to be less likely to receive services. And then when we look at those that have both co-occurring disorders or types of problems, there we no longer see racial and ethnic disparities, and we even see that the highest rates of use are for African-American youth. So this was some of our earlier work really thinking about the importance of considering problem types so that we didn't just say Latinx or children of color are less likely to receive services in general, that it might be really specific to the kinds of problems that we're attending to. Now, we wanted to follow this up and think about if we look at just the Latinx and Asian Pacific Islander families, so we looked at that subsample of about 460 kids and families. And here we were interested in thinking about what is the intersection between culture and service access. And the best way we could do that with these data was to think about the family's immigrant status. So whether the parents were born in the US or whether the parents were born in another country. And the goal here was to start to look a little bit more at the idea of adult distress thresholds, right? So the idea was that within an immigrant family, especially families that are Latinx or Asian Pacific Islanders, that we're more likely to see traditional cultural values that are characterized by interdependence, by a heavy emphasis on respect or filial piety and familism. And that within this cultural context, externalizing problems, things like being oppositional, talking back to other people, or to adults in particular, might be especially problematic. So when we think about looking at some of that earlier data, that the problem has to rise to the top for it to really be easily recognizable, that externalizing problems might be especially recognizable or important or distressing within immigrant Latinx families. That on the other hand, when we think about internalizing problems, that those types of behaviors are maybe more likely to be consistent with things like respect and obedience and interdependence, and that they may be relatively less distressing or more difficult to recognize or to identify as a problem. So here what we wanted to do is look at this issue of disparities by problem type by focusing on the family's immigrant status as a proxy for thinking about the level of culture. Now, quickly, when we looked at some of those predictors of service use in the next 2 years, again, we see that some of these practical barriers or potential barriers are really still important. Things like having access to insurance, that the Latinx families were still much more likely to receive services relative to the Asian Pacific Islander families. But that here it was really only the externalizing problems that predicted service use. There was no relationship between having an internalizing problem and receiving those services in the next 2 years. But our main questions here were to really understand whether this would differ by that family immigrant status. And that's a little bit easier to see in these next graphs here. So what these graphs show is the predicted probability of that child using services, again, in the next 2 years. And here in the lighter orange, we have US-born families, and in the darker orange, we have immigrant families. And what we see is that when we look at internalizing problems, children from immigrant families were much less likely to receive services relative to those from US-born families. But we see that opposite pattern when looking at externalizing problems, that in this context, it was the immigrant children that were much more likely to receive services compared to the children from US-born caregivers. Now, it's important to keep in mind that these are epidemiological data and that we're only looking at a variable like family immigrant status. So ideally, we'd want to look at a much more nuanced measure of culture. But this is what we had access to in this larger epidemiological data set. But I think that these differences were important nonetheless, or they were a really important first start for us to really be thinking about how do we unpack some of these disparities to be even more useful for dismantling disparities. And that even within an ethnic minority groups, we can see disparities as a function of problem type within immigrant and non-immigrant families. Now, in some of our more recent work, one of my graduate students, Tanya Galvin, has further looked at this subsample. And here she was just looking at the Latinx families. And what she wanted to do was to really look at that, again, on the left, we're looking at the probability of using services. But here what she's plotting is attempting to isolate the effects of caregiver acculturation. So here, just keep in mind that this graph is created based on a complete model. So we're controlling for everything, including the level of externalizing symptoms, insurance, you name it. And here, this yellow line that you see, this is the overall level of service use in this sample. So again, these are kids that were recruited because they were known to these systems, so they have a much higher likelihood of service use, about 42%. So the only thing we've done here is we say if we isolate those kids that have internalizing problems, again, clinically significant symptoms plus impairment, and those that don't have internalizing problems, after adjusting for everything else, what we see is that the caregiver's level of acculturation is predictive of the likelihood of them receiving services. So high likelihood overall, above the mean when we're looking at kids that don't have internalizing symptoms or problems. But when they do have clinically significant internalizing symptoms, it's only those at the highest level of caregiver acculturation that start to get close to the overall level of use. So what the graph suggests to us is that compared to those kids that don't have internalizing problems or internalizing need, youth with internalizing need are especially less likely to receive those services. And again, the key here is to really isolate what's the effect of acculturation specifically, and how is that interacting with a specific problem type like internalizing problems. So again, to summarize what we're looking at here is that this is that acculturation plays a particularly important role for determining whether or not Latinx youth receive services, in particular when they have internalizing problems. So this is a pattern of service use that's been of great interest to me, is really thinking about what is it about internalizing problems and why are those especially likely to go unnoticed, and why is that especially the case when we look at Latinx youth. So this has led to some work trying to think about how we identify needs. How is it that caregivers, that providers, that teachers start to think about when and why children need services? So here what we've done is we started to build on that study that I mentioned before, where we're looking at those stakeholder perspectives. And this was a mixed method study looking at families, Latinx families and providers in community mental health systems within Colorado. And the overall goal of this project was to really think about the complex interplay of factors that are related to, that lead to the creation of disparities, with the hope of then being able to develop interventions to undo those disparities. So the overall goal is really to think about how we inform intervention research, but also practice and policy. So with the support of our community partners at the Office of Behavioral Health, we recruited Latinx families who had already made contact with mental health services for their children. We thought this was an important group of Latinx families that had navigated those barriers and had been able to access services. We also worked with those families that had children and had never had any contact with mental health services, agency providers, and also managers and directors within those agencies. And these were across 3 counties in Colorado. So looking at 2 urban counties and 1 more rural county. And I'll be talking about some aspects of the study, not all of it, but we did combine survey methods to understand perceptions of barriers, and also some experimental vignettes that I'll go into in a second, to understand how providers and parents really think about severity, need for services, and when services might be appropriate. And again, this was all focused on Latinx families, whether it was from the perspective of the families or the perspective of their providers. So the experimental vignettes that we used were adapted from a study by Chavez and colleagues. And what we did is we developed or modified it so that we had 1 internalizing vignette and 1 externalizing vignette. These were of moderate severity. They had done lots of development to look at low, moderate, and high levels of severity. So we really wanted to focus in on those moderate levels and just have 1 that focused on internalizing problems, 1 that focused on externalizing problems. And here they rated how serious the problem was, how impairing it was, and what the need for services was on a scale from 1 to 10. And then we also had semi-structured focus groups where we talked with either the group of providers or the group of caregivers to get a better sense of how Latinx families identify mental health needs, and also to discuss and debrief about those vignettes. So to really think about how they responded to some of that clinical information. And here the goal was to move beyond looking at just clinical need or symptom type to say, what is it about a child's presentation that resonates with parents, or that signals to them that a mental health issue might be present. Very quickly, we provided usually dinner. So there's a meal, then they completed questionnaires, often with our support if they needed it. And then we followed that with a 1-hour focus group. These were audio recorded. They were conducted in either English or Spanish, depending on the participant's preference. They received an incentive, a meal, and childcare. And the analyses that I'm going to be talking about today, we transcribed those in the original language, so either in English or Spanish, and then took a directed content analysis approach. So we had some ideas about things that we were going to be looking for, things like impairment or symptom type. But we also wanted to really capitalize on the data to help us understand what is it about these experiences or these child behaviors that are resonating with parents or that are making them concerned. So just to give you a little bit of a sample of what this was, the internalizing vignette talks about a child who's been increasingly moody. They've been staying in their room after school. They've lost interest in their favorite hobbies. They don't feel like eating. The child is always very kind with other people, but lately seems sad and hopeless. Every day they say that they feel tired, even though they're sleeping more than normal. On some occasions, they've missed school. They follow the rules well, they're polite and respectful of parents and teachers, but in the last few months, they've been having trouble concentrating on what they're doing, both at school and at home. And they've recently told their parent that they feel worthless. So just a quick general description of a child with moderate levels of internalizing problems, according to Chavez and colleagues' pilot testing. And then the other vignette focused on externalizing problems. So this was a child who has a long-standing group of friends. They're the leader of that group. But over the past 6 months, they've started to lose their temper, argue with friends to put them down. They often get angry or appear resentful. They blame other people for their mistakes. And their friends have started to stay away from them because the child is overly sensitive or becomes easily annoyed. So they carry grudges lately, they're spiteful, they're vindictive. The kid has above average intelligence, they're very articulate, and they've maintained a B average in school without having to work too hard. But the child regularly defies their parents and teachers. They don't comply with adult requests and rules. Recently, the teachers have had to place the child in detention. And the child is arguing loudly with parents, teachers, more than other children their age. So again, a general example of a child with externalizing problems at a moderate level. And what we were interested in doing here is looking at what are the provider and caregivers' perceptions of how serious these problems are. So for each of these, what you'll see is that's rating of seriousness from 0 to 10. And when we look at providers, we see that the providers rated the externalizing problem as less serious than the internalizing problem. The families in services and the families not in services rated both of them at about an equal level of seriousness. So here, one thing that jumped out to us was that providers have lower ratings of seriousness across both types of vignettes, but they especially see the externalizing problems as less serious relatively than the internalizing problems. Now, when we look at perceptions of how these behaviors might impact the family, again, on that 0 to 10 scale, the providers rated both of these as about equally impairing for the family. But the family members or the caregivers rated the externalizing problems as more impairing at the level of the family than the internalizing problems. So again, here families are rating the externalizing problems as having more of an impact or more likely to have an impact on the family relative to internalizing problems. And the families see these externalizing problems as more impairing for families relative to what the providers think. This is a very similar pattern here looking at perceptions of peer impairment. So how much is this getting in the way of getting along with peers? And here it was the families not in services in particular that saw externalizing problems having an important impact on peers, much more so than those internalizing problems. And this was the only difference here that was statistically significant. So the families that were not yet in services believed that the externalizing problems would be would lead to greater peer impairment when the child had externalizing problems than when they had internalizing problems. And lastly, as we think about their perceptions of need for mental health services, so again, on the scale from 0 to 10, how much, what's the level of need that this child has? Providers saw significantly less need for mental health services related to externalizing problems than internalizing problems. So much more attuned to treating internalizing problems when we're looking at providers. And we saw the opposite when looking at caregivers. where they were either about the same or potentially slightly higher when thinking about need for services relative to external or for externalizing problems. So families still see high levels of need for both types of problems, but the providers were a little bit more more likely to be attuned to need when there's internalizing problems there. Now, what we wanted to do is, that was based on those vignette ratings, we wanted to step back and really think about how are families understanding this information? How is it that they believe or understand that children get referred, that problems get identified? So about a third of the discussion really focused on sources outside of the family. So really thinking about school personnel, primary care providers, other adults, right? So thinking about those adult gatekeepers. That this factor really resonated for the providers and the families that had access services. Interestingly, the families that had never accessed services didn't really make any mention of external sources. So I think from their perspective, they had no experience with having their child referred for services, but they believed that it would be something the family would recognize and then seek out. Those families that had experience and the providers really said, there's an important source here that is really outside of the family that often drives mental health need and mental health referrals. That's not going to be a surprise for any of you that work with children. But one of the things we were really interested in was, again, this idea of how are adults understanding need within these stories or within their children, right? What is it about the situation that really jumps out to them and suggests the presence of mental health problems that warrant services? And here what we see is that about half of the references in this qualitative data really focused on the clinical presentation. What is it about the presentation? What is it about the child, or what's going on with the family? And the type of problem accounted for about half of those. So here I'll switch to the next slide just to show you what some examples here were. But these were things like internalizing symptoms were clear to them, externalizing symptoms, the contrast between the two, or sometimes symptoms that couldn't easily be categorized. So here again, when we looked at coding some of these, it was really focused on the type of problem, and we define this as some aspect of the presentation that influences the need the perception that there is a need. So with internalizing problems, caregivers would say things like, she feels worthless, she won't talk to her friends, she doesn't feel like eating. For externalizing problems, he thinks he can do whatever he wants, I have no say-so, I say you can't go anywhere, and he takes off out the door. And then there was this category where it was really hard for us to know, is that an internalizing symptom or an externalizing symptom? But this was usually a mention of some notice in a change in behavior, but we just couldn't understand why that behavior was changing. So one example of that was a parent saying she started wearing black and she started listening to bad music. So they noticed that something was different. We didn't know much more about that. But these are three examples where three types of codes where both providers and caregivers are talking about what is it that they notice. And this was fairly easy for us to categorize into DSM language. One code that came up that was mostly driven by the providers was this problem contrast. So here we looked for a specific mention. So within the response where they're comparing the role of internalizing versus externalizing problems in deciding need. And the provider said things like, I see a large focus on behaviors more so than on possible underlying causes. So he's not paying attention at school, or he's disobeying his parents, or he's yelling more than maybe. So they're focusing on those behaviors more than maybe there's something like anxiety. So really focusing more on the observable behaviors. And in this case, for that code, the person had to specifically or explicitly talk about contrasting those types of problems. Now, as we think about impairment or distress, this was another important category. And here they really focused on things like, what's the impact on school and what's the impact on the family? So examples of this were things like, for school functioning, we thought it would pass, but now he's getting Fs. right? The school district was like, we're not going to allow him to come here anymore unless he's able to be controlled. So really thinking about what is it about the school that's demanding services, or at the level of the family. Difficulties getting along with the family, not spending time with the family, parents feeling overwhelmed. What was interesting to us is that there was no mention of the child's distress. So this is very much focused on the impact that it has on other people. I'm sure we would have had a different response if we'd included youth in these focus groups, but that here they're really focused on the impairment or the impact on school or on family. Some of the themes that came up less often were the severity of the problem. So something like recognizing that things are getting worse over time. And within that, parents were especially focused on thoughts related to self-harm or themes related to self-harm, that they were especially attuned to concerns about suicide or suicide risk. And one of the things that jumped out to us was that when they were thinking about their ratings of internalizing problems, if you remember back to those slides a couple minutes ago, that they rated those as in need of services or as highly problematic. Yet when they talked about them, they said they're concerned about them because they could lead to suicide. So they were often adjusting the level of severity and saying, I'm concerned about those symptoms because they could lead to something much worse. And lastly, one category that was especially important for the families, or especially common where families accounted for more than half of those references, was precipitating stressors. So they talked about things like a parent being deported or trauma, exposure, or divorce. So that often for families, they saw need as being driven by an external event, right? There's something happened and that's the reason for it. So when we step back and start to think about this pattern overall across our qualitative and quantitative data, general themes like for the families, the externalizing vignettes seem to lead to higher ratings of seriousness, and they're more concerned about those symptoms impacting family and peer functioning. That the providers seem to be much more attuned to the seriousness of internalizing problems and consider those worthy of treatment. And that as we step back and look at how families and providers are thinking about mental health need, that we see this broader category of many different ways that needs get identified, including sources outside of the family, sometimes thinking about the problem just like a mental health professional might, where we focus on the symptoms, but often really thinking about what is that impact, what is the impact of this behavior on school, what's the severity, and am I concerned about my child's safety and well-being, and often thinking about what happened in their life, right? What are the things that happened to them? Now, when we step back and start to unpack this, we think about, this has important implications for how we really start to move our understanding of disparities, how they come to be, and what to do about them. And it built on this early work that we did where we looked at those patterns of service use for kids with externalizing problems and said that there might be more, it might be easier for families to be attuned to those difficulties because they're easier to recognize. They're also more problematic to others outside of the family. But how do we also start to balance that out with paying attention to the internalizing symptoms? And that we really need to spend much more time in our research, especially thinking about explicitly focusing on how families seek services. That from my perspective, my intake might focus a lot on diagnostic interviewing, but that I need to also think about this from the research perspective or from the clinical perspective. How is it that this family came to seek services? So as we think about changing, that we want to really redefine how we think about need. And that doesn't mean that we shouldn't or can't use diagnostic labels, but that we at the same time want to be really thinking about how is the family defining need? What does need mean to them? And what is it that they're saying? That we need to provide education, especially around internalizing symptoms, and really think about youth distress, right? That this is one piece that seems to be missed, both by providers and by caregivers. And if we think about how closely that is connected to internalizing symptoms, that might be a really important focus for education going forward. How do we provide education about what internalizing symptoms are and start to recognize youth distress as also another important component of deciding when kids need services? And lastly, to be thinking about the importance of internalizing problems at moderate levels. That again, families seem to recognize those as important problems, but they seemed much more attuned to their concerns are much more focused on what severe levels of internalizing problems look like once they're very closely connected to suicide risk. So really thinking about the broader range of internalizing problems and how one might get better at noticing those or assessing those or learning about them. So as we start to think about what's the role for the provider, right? That we're thinking about a very narrow slice of the pie here, where we're thinking about those families that are having contact with a provider. And the first step is really just having that general understanding of the broader social and cultural context. So understanding how kids came to be connected with services, I think, is a really important key. Often what we see, or what I see in my own practice, is there's a teacher that believes there's ADHD, and then the parents believe that the child has ADHD, and then they come ask you, does my child have ADHD? You ask them questions about ADHD, and then everybody agrees that they have ADHD. And they very well may have ADHD, but that if we're really thinking about a social justice perspective, where we want to make sure that all children have access to care regardless of race, ethnicity, or symptom presentation, that it really warrants that we take a much more comprehensive approach to assessment, and saying, let's understand the social processes that lead to a child showing up at my clinic door. And also let's rely on really good assessment strategies for saying, let me just also assess for a wide range of clinical issues. One, because some are likely to be missed, and two, because we're very aware that comorbidity is the rule rather than the exception. It also forces us to really think about, how do we engage families, right? And the work of Lily and Comas-Diaz really focuses on giving families the opportunity to tell us what happened to them, right? To give them voice, to help them understand and construct their experience, and to really focus on how is it that the family understands or describes what this problem is, how it developed. So in the interest of time, I'm going to move very quickly. I do want to highlight the work of some of your colleagues there at UCSF, who've written a wonderful chapter really thinking about how we understand engagement. And they really talk about it as trying to align those perspectives. How do we get an overlap between the way the child sees a problem, a caregiver sees a problem, a clinician, and a broader service system? How do these perspectives overlap? And that if we have the opportunity to get as much overlap as possible, that's really going to maximize our chances for engaging that family. And that it starts from being really clear about what is it that the family is recognizing. What is it that they're identifying? What is the problem from their own perspective? Now, when I do trainings, I often talk about the DSM-5 cultural formulation interview. If you have never used it or were not aware of it, it's something that was developed with the DSM-5. It's available as part of the DSM, or if you look for it online, it's the first result that pops up. And what I think is really useful about it is that it just gives you sample questions to really think about, what information do I need to be assessing during my intake to maximize the chance that we can align perspectives. So it starts by questions around, what is their definition of the problem? How would they explain it to other people? What do they think causes it? What makes it worse? What makes it better? So really important things for understanding the broader cultural context for the problem, but starting with that really good assessment of, how is this family seeing things? And that's going to give us the maximum opportunity to really talk about the problem in a way that resonates with the family, and in a way that maximizes that ability for engagement. I'm realizing that I'm almost out of time here, so what I want to do is I'll stop here for questions. I'm happy to, again, send you some of these slides if you have other questions, or if you want some of these resources, but I'll stop here just so that we have some time for questions.
Thank you so much, Dr. Gudiño. I could listen to you for another hour, but we don't have it. But I like to call on Dr. Will Martinez, who has a question.
Yeah.
Go ahead, Will.
Yeah, I'll keep this brief, and thank you so much, Dr. Gudiño. Yeah. It's great to see you here. And
how are you, Will?
This is great. Nice to see you.
Yeah.
this has been a great presentation. I mean, I could go on, as Dr. Stewart said, on how much this aligns with a lot of the work that we're doing here and what we're seeing both in our clinics and in the county. But question for you, with a lot of programs here and across the country transitioning to telehealth, how do you see that impacting this in any type of way? You know, we've seen both increased engagement, but then also the barriers come up around technology, and trying to really understand what kind of impact this is having, particularly on our Latinx families.
You know, I don't know that we have good data yet, but my sense so far is that there's really a subset of Latinx families where this has been really useful. And for those that were able to get supports from the school system to access school in this way, that there's a lot more familiarity and you know, they whether they got a hotspot or whether they got a computer, that experience is there. And for those families, I think it's really been useful. And for those where that was the initial barrier, in some ways they've become even more disengaged, right? So I think it's been great for a subset of Latinx families. And I think it's a wonderful tool to rely on and to maybe increase access for some Latinx kids, but we're still going to really need to think about what we do for those that are not able to do something like log in or have a private space at home where they can do a mental health session.
So I have a few questions from Dr. Marina Toulouchan. So she'd like to understand a little bit more about the externalizing. And Marina, if you're still on, you could ask your question yourself. Go ahead.
I am. I realized we only have a minute left. Thank you so much for your excellent presentation. I wrote to Barbara, I have like 5 questions all out of like excited interest, but one was really wanting to understand how you're conceptualizing this in terms of co-occurring, internalizing and externalizing. And is this like a primary kind of presentation? And I just would love to hear your thoughts on that, both from your large data set work and then this work that you're doing right now.
Yeah, so the way we think about it is, again, most kids have a combination of problems. And when we've looked at kids with comorbidities, it's the likelihood of accessing services and the rates of disparities are lower. And we think that's driven by the fact that they have externalizing symptoms. So it's only when you isolate the effects of one versus the other that we're really concerned about kids that only have internalizing symptoms, and that those are really likely to go unnoticed or really likely to fly under the radar until they get very severe.
That's right.
So for better or for worse, if the child has co-occurring problems, they'll have some of those more observable or more disruptive problems that are easily seen by other people, or that create problems at school and at home. And that's what seems to carry the day in terms of getting kids referrals.
Yeah, and so that was my second question, because we do a lot of work in juvenile justice, and we know that kids present primarily with externalizing, but actually our data show there are really high rates of internalizing disorders, and there's a lot of work being done around suicide risk in that population. And I know we don't have time for it today, but I would love to hear your thoughts more about this work in Latinx families involved in the justice system. And I was wondering, like, what proportion of the immigrant families are also involved in justice system, which we see here a lot in California. So anyway, thank you very much.
The short answer to that question is that we've done some work looking at inpatient youth and youth and juvenile justice. And there, I think kind of a trauma-informed approach to understanding mental health has been really useful, in that often we think about introducing trauma history and trauma symptom measures as a way to make sure that we're capturing some of those internalizing problems, and then helping kids, providers, and families see those connections between what's happened to them and the range of problems that they're showing up with, even if it's the externalizing problems that got them arrested.
Well, we should end there. Thank you so much. I look forward to reading your papers that are currently in press and that we could get a hold of soon enough. Take good care. Be well, everyone. Have a great afternoon. And thank you very, very much, Dr. Gudiño, for your time.
It's good seeing all of you.
Take care.